Welcome to the official podcast of the Ogden Surgical-Medical Society. Since 1945, the Ogden Surgical-Medical Society has been educating our medical community. In this podcast, we bring you the voices of medical experts in your community and from around the world. Please note that the opinions and ideas shared on this podcast are those of the speakers and not the opinions of the Ogden Surgical-Medical Society or its board. While medical topics will be discussed, it should not be taken as strict medical advice, and individual clinical judgment is warranted in applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed with regards to their medical practice. My name is Clark Madsen. I'm a family physician and sports medicine physician at McCady Hospital in Ogden, Utah, and I teach family medicine at our residency. I'm on the board of the Ogden Surgical-Medical Society, and I am here with my good friend Heather.
This is Heather Hylison. I'm an emergency physician at McCady Hospital. I work with our guest speaker today, our partners. It's Dr. Amber Mounday. She obtained her chemical engineering degree from the University of Kansas while competing in track and field, specifically doing heptathlons and hurdles and jumps. She completed medical school at the University of Kansas and then residency at Washington University in St. Louis. And she's just always been super active in sports and was actually throughout residency and medical school competing on the elite pro level and doing triathlons and things, which just completely blows my mind.
I had no social life. Let's just admit it.
We brought you in because we have some very interesting topics to discuss. And we're going to be talking about athlete's heart and the cardiac changes that can happen in some athletes, both the physiological ones and also the pathological side of it. But I think before we jump really into that, a question that everybody has asked themselves right now is how in the world you could compete at that level and go to medical school at the same time.
That is a very good question. Well, let's just say I felt like the first couple of years I had a lot of free time on my hands, especially since being a Division I athlete. That was pretty much a part-time job. And then when I started medical school, I probably to my detriment became very interested in triathlon. And there was a great club and opportunities in Kansas City to meet people outside of school. And so it was a nice outlet, but it quickly turned into more than that. But yeah, I had to negotiate on a few of my rotations. Not everyone was as enthusiastic about supporting my other endeavors, but I managed to make it work. But yeah, I think it did lead. And this is, great that this ties into our topic, is that I did experience quite a bit of issues with overtraining, not only through medical school, but also residency. And I was starting to have some arrhythmias on and off, and probably, when I look back, some sort of decrease in performance, which was probably directly related to the cardiac issues I developed over time.
That's getting us right into the main goal of our conversation today, to talk about athlete's heart. Before we get too much into it, can you kind of explain what we're talking about with the athlete's heart and what that means to you?
Sure. So over sort of repetitive training and volume, and you do have to consider this is different for every sport. So an endurance athlete, much like I was, is very different than what you see in sort of strength-based training. So your football players, your weightlifters are going to have a very different physiologic adaptation to training than someone that's doing more of an endurance type or endurance-based sport. So what happens over time is you start getting physiologic changes based on the stress that's put on the heart, which is a muscle like any other muscle. And interesting enough, you get different patterns of not only hypertrophy, but also you can end up getting dilation. And that's the big thing we see with endurance athletes, is they start to develop some right-sided issues, more so than left-sided issues, because of that reason, that there's a lot more demand as far as pulmonary blood flow. And the right side, which is becoming more appreciated, tends to not probably do as well, physiologically over time. It tends to be more susceptible to developing fibrosis, particularly.
That's kind of the interesting thing, I think. I mean, we are always encouraging patients to exercise, to be physically active. And we always talk about exercise as being this medicine that doesn't have any side effects to it.
Right.
But you're kind of showing us that, at the extreme end, there are some things we should be aware of with this.
Yeah. And I think it's becoming, this is all pretty recent data, but, you bring up a very good point. With many things, moderation is probably the key. And there have been some good studies that show that there's sort of a U-shaped curve as far as health benefits. So, those on the lower spectrum certainly could sort of get themselves up to better fitness levels. But those who kind of go above and beyond as far as intensity and duration, which is thought to be anything more than sometimes an hour a day. But, the interesting thing about this problem is that not everyone is susceptible to having these issues. And we're still sort of elucidating what those risk factors are. There are the common risk factors that are much like any other sort of cardiac disease: hypertension, sleep apnea. There are actually a lot of athletes that go undiagnosed, probably because of their body habitus being so fit. It's just assumed that they don't have sleep apnea. But that is a risk factor, much like you see in the general population, that needs to be considered also in athletes.
So I like the idea of moderation in all things, but my idea of moderation is probably very much different from your idea of moderation.
Right, exactly, yeah.
So at what point when you're exercising do you start thinking, am I pushing myself too hard? How do you know when you need to cut back? Yeah,
and that is kind of ties back into the definition of athlete's heart syndrome. So for most people, these physiologic changes are asymptomatic. So over time, you start to have these adaptations. You're getting fitter, you're feeling better, you can go longer. But in some people, it starts to become maladaptive. And then you start to develop symptomatology. And that's probably the best way of sort of defining what is maybe too much for the individual. And like I said, there are a lot of different factors that play into that. Even probably genetics for a lot of people. And we could go into talking about sort of acquired versus hereditary cardiomyopathies, but that may get us a little too far off track.
Maybe another episode.
I could spend another 2 hours talking about all of that. But
it's interesting to know that there is a hereditary component, though.
Yeah, but
not just obesity.
Yeah, and it's really interesting, some of the studies that have been done in endurance athletes, and in fact, for one example of acquired, right ventricular cardiomyopathy, it was found almost exclusively in endurance athletes when they look back at this study.
Interesting.
But they've done some good longitudinal studies in Scandinavia, primarily because they tend to be really Nordic focused. And so they've got this great pool of athletes, and they've really shown that over time, there are certain risk factors for specifically developing atrial fibrillation. But it has a lot to do with lifetime hours. It is sort of what people are starting to look at in athletes. So, you look at me personally, probably part of the reason that I had so much trouble or now have developed cardiomyopathy is because I never really had any time off. I've always been competing my entire life. I could only guess what my lifetime hours are at this point. Probably even it would shock me if I were to really sit down and add it all up.
So by lifetime hours, you're like all of the, the experiences over your whole lifetime building up in a kind of a theoretical bank.
Yes, exactly. Yeah, because the heart is a muscle like any other. It needs time to recover. You get this repetitive microdamage, which leads to inflammation, which leads to developing cardiac fibrosis because of this inability to heal correctly after these insults. And that's seen more in endurance athletes because of the intensity and the duration that they sort of subject their physiology to. And you do that time after time, race after race, year after year, it starts to really add up in some people.
Yeah, I was going to ask you about that, because is there more of a link with the intensity of the workout? It's more sporadic, or is it more the endurance and the actual time and pushing the heart, or what have they found?
Part of that study in Scandinavia, which was really interesting, is that there was a correlation with intensity. So they found that the rate of AFib was significantly more in people that had faster finishing times. So it does seem to be intensity related. And so they found, especially when you're competing at an elite level, and we're talking a very small percentage of the population, right? That's probably training and competing at this level. But I think as more people start to participate in these type of sports, I think it's something to recognize that if you had somebody come into your office complaining and they're an athlete, first you want to ask them what sport they're involved in, because it's going to be very different, like I said, between a football player that's developing this sort of hypertrophy and an endurance athlete developing the same type of left ventricular hypertrophy. It's going to be much more concerning in the endurance athlete. So you have to sort of look at what sport they're involved in, and then you have to sort of talk to them about maybe their overall training hours and then sort of their symptomatology. So if somebody's starting to have palpitations, lightheadedness, near syncope, even reduction in, performance, and this is probably even good with even college age athletes, if they're starting to have those sort of what we used to describe as overtraining syndrome, you really have to make sure they're not having any cardiac problems.
Yeah, I mean, in sports medicine, overtraining syndrome, or what is kind of this nebulous term we give to, people who are starting to decline despite training even harder than they have in the past. And so this is a new way to look at it. There's probably a good number of these who are probably early on in their cardiomyopathy stages, but we're just telling them they need to change their shoes or maybe take a break for a day or two. It's a bigger thing than that.
It is. And there's been some really interesting study in college athletes, such as myself, that go on to continue to compete or develop problems later on. And what are some of those identifying factors? One of which is very interesting is the rates of hypertension that are probably going undiagnosed. It's not to be as high as 30%. And at that age, a lot of times you're normotensive at rest, but you start to develop, as part of that physiologic sort of adaptation, as you develop this exaggerated sympathetic response, and then you end up having more hypertension than maybe the average elite athlete would have.
It's really interesting because you often think about exercise as something to do to lower your blood pressure.
Yeah.
I guess it's the extreme. So what are some of the other end results of athletic heart syndrome?
Yeah, so like I said, it kind of starts out as a physiologic adaptation. And so you usually end up initially maybe having some EKG changes. And so there's suggestion that you're starting to develop some electrophysiologic problems. And then you start to have, like I said, problems with structure and function. So if it goes untreated and you don't go through a period of sort of addressing that, you start to develop decreased cardiac output. You start to get, abnormal hypertrophy of the heart, which ultimately leads to scarring and then potentially becomes arrhythmogenic. So, and then over time, if that's allowed to continue, you start to develop tachyarrhythmias. I'd say bradycardia is very common in athletes, especially endurance athletes, but you can start to develop abnormal arrhythmias, which can be life-threatening. So that's a real, reason to sort of get this treated probably early or recognize it early in somebody's career so that they can sort of prevent those sort of end results that occur that are permanent. A lot of athletes' heart syndrome is reversible. Given a period of detraining is the term that's now used. And like you said, it's not just a couple of days. There's one study that suggested it needs to be probably up to 24 weeks to really see a reversal of that hypertrophy. And the studies really bear out it works well. There was a study done on an Italian cyclist who had high rates of PVCs and then also frequent NSVT. And they showed, after a period of detraining, almost a 90% reduction in the number of PVCs. And the great thing is when they got back to training, they did not come back or reoccur. And some of that could be they modified their training programs sort of to build in more rest time. But I thought that was a really interesting study.
Yeah. So, it seems that there's a point at which this is somewhat reversible. Mm-hmm. And then there's a point at which it's no longer reversible when the scarring starts to happen.
Right. Yep.
Is there any easy way to differentiate when that's going to happen?
I don't think so.
Okay.
I don't think there's really a good answer to that. And like I said, we're talking about such a small percent of not only the population, but then also of athletes. And so a lot of the challenge with research in this group is there's just such a, overall, there's a really low rate of prevalence, right? Like we're dealing with a very specialized portion of athletes. However, I think we're going to see this more and more as kids start training at earlier ages, becoming more serious about sports and sort of specifying early, through the club programs, and the fact that more people are getting involved in sort of these endurance type events. I think this is something that really needs to be on our radar as far as treating sort of even those who consider themselves just weekend warriors.
Yeah. All right, we're going to take a quick little break from our conversation. We're going to get back to it, but I think this is also a good opportunity for our listeners to get to know our interviewee, especially because many of us work with you in the community. We'd like to see if you have a recommendation for us, either a book or a movie or something that's in your life currently that you really enjoy that you want to share with us. And I was just going to mention, for me, a recommendation I have is a book called The Happiness Trap. And to be honest, I do not remember who wrote that. Dr. Blaisdell's going to get after me for this. But so this is a book about, it's written for patients, but it's a book about how to do the ACT form of therapy, or the acceptance and commitment therapy, which is a type of cognitive behavioral therapy. And it helps, patients kind of read it. And I've had a lot of patients who really enjoyed it and helped them with their anxiety. So it was written by Russ Harris and Stephen Hayes. Anyway, that was my recommendation. Do you have any recommendations for our listeners?
Yeah, well, I just gave my friend my favorite book probably in the last year, which is The Overstory. And that was written by Richard Powers. It really was about, it was sort of a modern day fable about our relationship with trees, and sort of not only kind of the environmental impact that really we have caused as far as the devastation of forests, but also our relationship with the forests moving forward. So I really enjoyed that book quite a bit.
I think I read a section of that. There was a part of the book where they were talking about how trees kind of communicate with each other through their root system.
That's right.
That was really interesting.
It's interesting that researcher initially was sort of shunned by her. It reminds me of things that have happened in medicine that are similar, like H. pylori is probably my favorite example of researchers that were just completely shunned by the community. This is ridiculous. Like, how could you even possibly think that a bacteria is causing ulcers? That is just... and she sort of had the same response and got blackballed by her own research community when she first came out with that, which was later validated, study after study, that yes, trees do in fact communicate through their root system. So... yeah,
it's really
great.
So
interesting.
It was a great book.
Dr. Haddison, you got anything you want to add? You don't have to. I think we've got some good recs today. So I think
hate to sound boring, but I feel guilty every time I try to read something non-medical. When I look over at my pile of throwaway journals, and I'm like, I really need to just read
it's
those.
hard.
So
I
listen to podcasts.
How's that?
Yes. So I will make a quick plug for if there's any interest out there and reading more about this topic. There is a great elite cyclist, electrophysiologist, John Mandrola, who wrote The Haywire Heart a few years ago. That was really well written. He does a nice job summarizing sort of the current research and then sort of what it means for the elite athlete that maybe is having these issues. I found that book very helpful.
Well, I think that's a good segue to get back into it. We've talked about some specifics of this, and maybe we can kind of take a step back Would you be able to kind of walk us through how an athlete may middle age or 30s, 40s having or later having these symptoms? How did this all begin? Kind of give us a picture of someone who may have this syndrome from their early years training to later on.
I'd say as far as what I experience now, people approaching me, other, fellow athletes, the most common complaint I usually get is, hey, I've been having a lot of palpitations. So I think that's generally what usually people experience most commonly. And most of the time they are benign, but they can be a harbinger for other sort of, pathology. And I think anytime someone maybe presents to your office with these complaints, it should be taken seriously, especially in athletes. Mm-hmm. So I'd say that's probably the most common, sort of issue that people typically complain of. And I think it's because it's the most noticeable. Mm-hmm. So we can usually make excuses for other things that we're feeling, like fatigue and, getting lightheaded during races. But when people start experiencing palpitations, I think they have a very, we all sort of have a stress response to that, I think, when you start feeling those. So I think that's the more typical presentation, and that is typically seen in people, the average people without hereditary. If you look at how this sort of plays out, is that, in your 20s, it tends to be more of those channelopathies like, prolonged QT, WPW, those present at an earlier age. And then when you get into your 30s, it's more of the cardiomyopathies that we think about, like hypertrophic cardiomyopathy probably being the one most people know about. And then as you get older, then you start to have a concern for more, issues with potentially coronary disease, even in athletes who seem healthy.
Knowing that, is there anything that you would do differently if you had to do it all again?
I would say my first experience was when I was in college, and I would say, this has been quite some time ago. So there wasn't really the knowledge, I think, that exists now. But I was, when I increased my training load from high school to college, that was the first time I started experiencing a lot of palpitations. And I was getting a lot of frequent, premature atrial contractions, or PACs. And it was enough. I was starting to get some short little runs. And that was when I approached our family physician at the time during the summer, and I said, hey, I'm having these palpitations. I don't feel like I'm having any other symptoms. And I ended up getting an echocardiogram and an EKG. And, at that time, structurally normal heart, you're fine. Mm-hmm. And I was basically told I was fine. There wasn't really this knowledge about athlete's heart syndrome. And so over the years, every time I'd experienced these sort of episodes or palpitations, I just played it off as benign. Like, this is fine, like nothing to worry about, until I started having more symptoms, and about 5 years ago, I had some really long runs of SVT, up to an hour, and then had some near syncopal episodes in a couple of races, which really scared me. Mm-hmm. One of which was during the start of a triathlon. I thought I was going to drown. So it got to the point where I couldn't ignore that anymore. Right. So.
It's hard to think, well, I'm just needing to train more. I'm just short of breath because I'm deconditioned. I need to train more. Yeah.
Yeah. And that is sort of, you can talk about the psychology of a sport, and certainly there are personalities, much like mine, that are probably self-destructive, because if to that very end, there are a lot of times that I thought I was underperforming because I wasn't training enough, when in all actuality, if I'd cut significantly back on training hours, I might have performed at the same level, mm-hmm. or I'm guessing probably better. And that's the interesting thing. And the challenge with treating endurance athletes is the last thing they probably want to hear is that they need to cut their training load by at least 50% mm-hmm. for 4 months. Very few are probably, that's just a lot to wrap your head around, especially when you have goals and aspirations, or if you're competing on an elite level and you want to, qualify for Boston, or you have these other goals, that's probably a lot to ask somebody who's sort of wrapped their lifestyle around it.
Right. It's not just about the Starling curve and getting that muscle going, but it's about fibrosis and dilatation of your atria.
That's right. Yep.
From your experience in talking to your friends, what would you recommend that the average physician does if they see someone that they suspect may have this developing? Mm-hmm. What should they do immediately? Who should they get them to? What would your thoughts be?
Yeah, well, now having gone through it, I feel like I have a better sense of maybe what a good approach is. So I think it's very reasonable to get a screening EKG. I think, though, the caveat being is you need to know what you're reading. So what you find in athletes as far as EKG findings could be considered abnormal in the general population, but in someone that's training on an elite level or running marathons, it may be perfectly normal that they have an incomplete right bundle or they have profound sinus bradycardia. Like that may just be their baseline. And so there are some EKG criteria that have been published. You can find these on the sort of British Medical Journal Sports Medicine website. But I think to that end, I would probably recommend referral to sports medicine, and at least here in the Ogden area to you folks at McCady, either Dr. Sharman or Dr. Matson is who I'd recommend referring athletes to if there's some concern.
Well, I'm flattered by that.
You did finish that video training on
I did
EKG reads.
No, I mean, that's really good to bring up. There is some special criteria for reading EKGs in athletes, and the current setup is called the international criteria. It's interesting because in certain situations, even having ST elevations can be normal in a specific situation. And so just putting athletes in a blanket with everybody else, you're gonna have some mistakes. And so that's really But on top of that, you can't just assume if something's abnormal, it's just because they're an athlete.
True. And so the challenge being is you have to balance. And there is some controversy about screening EKG, especially in college athletes right now in the United States. Some people are against it, even in cardiology, because of the concern for over-diagnosing and treating. That we're still sort of, and those revisions, those international criteria were just recently revised, but it gives you a sense that we're going to probably continue to revise those recommendations as far as screening. But I still think in somebody that's developing symptoms, and that's the sort of big differentiation between people that are asymptomatic, so you're just doing blanket screening on all athletes, versus people that are developing or having concerning symptoms. And like I discussed, syncope, palpitations, lightheadedness, family history of cardiomyopathy is probably another one that should be asked, even by primary care. Should be taking a good family history with any sort of pre-sports physical. But that's why I think it's important maybe in regard to this to refer to sports medicine. I don't think it's necessary to refer initially to cardiology. There are other tests that may be considered down the road, depending on symptomatology. Obviously, it's looking to make sure you have a structurally normal heart, so an echocardiogram. Sometimes the stress test is indicated, but there again, that can overdiagnose and treat.
And I think you brought up a good point too. If you are going to get a cardiologist involved, probably make sure that they know that your patient is, the extent of it they're exercising. A lot of our cardiologists are used to dealing with patients who do little to no activity. They need to know that your patient is coming to see them because they do a lot of activity.
Yeah. So. In fact, I found myself getting a little bit exasperated because I think, and especially women athletes, tend to get a little marginalized. Like, I don't think I initially did a good job. And some of this is because you don't want to feel like you're bragging about, the training hours and racing and everything else that you do. But like you said, I think it became clear to me it was very important that people knew my past experiences, like how much I had trained and then how much I was currently training. And to the normal person, they probably couldn't wrap their head around training 500 hours a year. Mm-hmm. I mean, that seems crazy. Mm-hmm. But to me, that's not crazy because I have a whole community of people that I know that's their lifestyle also, mm-hmm. that's normal to them. And so I kind of forget that I have to, at least for me, I had to explain that. And I didn't think I did a very good job initially. So I think it's also important that the physician advocate also for their patient if they are making a referral to cardiology.
That's great. And I had one more question to ask you before we finish up here today. And it's kind of it's a tough and personal question. So if you don't want to answer it, please don't. But, I've seen this happen a few times with our athletes who end up having a medical condition, and it does change what you see yourself as. I mean, it changes your ability to compete at the level you're used to or wanting to compete at. Mm-hmm. And that can affect your way you see yourself as an athlete. Mm-hmm. How kind of from a mental health point of view, how did you deal with kind of changing your goals and your expectations for yourself?
I'd say initially not very well. You're right. I sort of went through this, I wouldn't call it an identity crisis, but it had been such a part of my life for so long. And it's hard not to define yourself in some way through that. And I think when people initially asked me that, I hadn't quite wrapped my head around it yet. But now I think looking back, I think that's really important, and especially when we're treating our patients and athletes. And we really need to consider that, because I think we get sort of wrapped up in the nuts and bolts and the pathophysiology, and we forget that there's this mental aspect, and that a lot of these people that have competed on that level, or this is their passion, to sort of suddenly be told that, this has been unhealthy. I mean, my first response was I was angry. I was upset. I never thought that this would happen to me. And then I thought it was unfair. But I think I've grown to realize that, I don't have to completely give it up. And I think it's been a good journey to figure out, what else drives me as far as enjoyment. Yes, competing and, going to races and sort of being a part of that culture was really important. But I tell you what, I skied this morning, and I show up at the parking lot. The grooming of the Nordic track was absolutely perfect, and I was the only one there. And I kept it to an hour. I skied really easy, and I had just a wonderful time being out. And I think I recognized that a lot of what drove me is that I just like being out on the trail. And so I find a lot of enjoyment in that. But I'm still competitive. I mean, some of it's just accepting who you are. You're like, yeah, I'm not going to be perfect. Like I still go out and, I see people race off in front of me, and the first thing I want to do, I'm like a puppy. I want to chase after them and run them down.
Actually, Amber, any takeaways you can give us? Just a summary of what, maybe 2 or 3 things you want our listeners to take away from your...
just the recognition that, like we talked about, exercise should be in moderation, that there is more and more data suggesting that excessiveness can even be unhealthy in exercise, and to, at least recognize and understand athlete's heart syndrome, and then also sort of being an advocate for your patient and making sure that they get the referral they need.
All right. Well, again, thank you. I think this is going to be, a real big help for those listening to it. And, especially where we live, we have a lot of, a lot of our patients are out there doing this day in and day out, and we need to keep our eyes open. I was looking recently, and Utah is one of the states in the country that has the highest exercise rates of any state. So we're going to have these patients and keep an eye out for them.
Yeah.
So thank you.
And I'd be happy to answer any questions that anyone has. Be happy to answer questions by phone or email within the Intermountain system.
Thank you so much.
But I always joke that I do not want to see people at my office, which is the emergency department.
Don't refer them to Amber unless
Please,
you absolutely need to.
Please don't come see me at the office.
Well, thanks again. This has been another episode of the Ogden Surgical-Medical Society podcast, and we've really appreciated having you with us. Hope you can take something from this and continue to provide the best care possible in our hometown here. And until our next one, thanks for listening.
The producers for this podcast are Clark Madsen, MD, MS, Teresa Pasquedra, MPC, and the Ogden Surgical-Medical Society Board of Directors. The executive director is Teresa Pasquedra, MPC. Your hosts for this episode are Clark Madsen, MD, MS, and Heather Hylison, MD. Editing and sound design is by Colton Gomez, and this is all supported by members of the Ogden Surgical-Medical Society.